Thank you for attending our Baby's First Test webinar, Improving Newborn Screening Rates within the Michigan Homebirth Community. Please remember that all of your lines are automatically muted. If you have a question throughout the webinar, please type them into the questions box located on your side navigation. Now to give you some background on our presenters. Lois Turbot has been involved in public health nursing for more than 25 years and currently works as the newborn screening nurse consultant. She has provided education, consultant, and care coordination services for Children's Special Health Care Services for years and joined the Newborn Screening Follow-Up Program in 2011 to enhance all aspects of newborn screening education and to provide consultant and evaluation for Michigan's nursery and midwives. Janice Bach has over 30 years of experience with all facets of state genomics program and is the state genetics coordinator and manager of the Genomics and Genetic Disorders section. Janice has a long history of grant implementation, serving as project director, co-director of federal grants and cooperative agreements related to genetics planning and implementation of the state genetics plan, the Region 4 Genetics Collaborative, and birth defect surveillance and follow-up. And finally, Valerie Newton is the CSHCS coordinator for Branch and Hillsdale counties. She has been working at the health department since 2005 and is responsible for overseeing the delivery of hearing and vision screening in Branch and Hillsdale counties. Under her leadership, the health department has expanded both their CSHCS services and their hearing and vision screening opportunities into the Amish community, which are now offered at a dozen Amish schools. Now we will have our presentation.
Hey, good afternoon, everyone. This is Janice Bach. I hope everybody can see our slides. Are we okay, Talia?
Yes, we're very okay.
Oh, okay. All right. And thank you for inviting us to share information about our Challenge Award project. You could say our project began in early 2011 when Lois, our newborn screening nurse consultant, received a call from a woman who is friends with Amish midwives, 2 in the county where she lives and 2 in an adjacent county. The midwives had expressed interest in learning how to collect a newborn screening blood spot and wondered if the newborn screening program could provide this service. Our newborn screening program epidemiologist was able to determine that both of the counties involved had a high percentage of missed screens on infants born at home. At the time, we did not have any program funding earmarked to provide this type of on-site training, and were therefore grateful to learn soon afterwards about the chance to apply for the 2013 Baby's First Test Challenge Award. For those of you who may not be overly familiar with Michigan geography, this is a map of showing our 83 Michigan counties, 15 in the Upper Peninsula and 68 in the Lower Peninsula. Based on information we were able to gather, there are 1 or more Amish church districts in 23 Michigan counties. The counties shaded in pink and magenta have Amish communities. Counties highlighted in turquoise are where 2 of our 4 training sessions were held, which Lois will be talking about a little later. Mecosta and Montcalm counties are the counties highlighted in magenta in the middle of the map. And those will become relevant later on. By law, all birth attendants in Michigan must offer newborn screening. Michigan does not license direct entry midwives and certified professional midwives. However, certified nurse midwives are licensed but are more likely to practice in a hospital or birth center. Once a week, our newborn screening program links the newborn screening database to birth certificates in order to find missed screens. Because of this, our program epidemiologist was able to determine that there were 480 infants born at home in 2011 who did not receive a newborn screen. Some of the birth certificate variables include if an infant is deceased following birth, the place of birth, and birth attendant. We can usually know it is a midwife-attended home birth, although the midwife's name might not actually be listed on the birth certificate. Compared to the overall newborn screening rate of 99.6% in Michigan, only 65% of midwife-attended home births received a newborn screen. The screens that are done are more likely to be collected late, after 36 hours, and are slow to arrive to the state lab for testing. This brings us to our 2013 Baby's First Test Challenge Award, which I will let Lois talk about.
Thanks, Janice. We had 3 project goals. First, we wanted to understand why approximately 1/3 of infants born at home did not receive a screen, and then what could be done about it. Our first step was to complete a survey. Our program epidemiologists received IRB exemption since the survey did not involve human subjects. We then chose to survey midwives known to have attended 3 or more home births because it seemed to distinguish true midwives from births attended by a family member, unintended home births, etc. We formed an advisory committee to develop survey questions. Members included staff from the State Newborn Screening Lab, Newborn Screening Follow-Up staff, and EDDI staff. The Michigan Midwives Association is a group that has been actively pursuing midwife licensure in Michigan. As Janice mentioned earlier, direct entry and certified professional midwives are not licensed in Michigan. The MMA also actively promotes newborn screening. Therefore, after we completed the survey, we asked a committee member to review the survey for us, which she did. We would be happy to share this survey with anyone who wants it. My contact information is at the end of this presentation. The survey had several modules. Though birth attendants are required to offer newborn screening, the parents must obtain the card. Most of the midwives that I have spoken to instruct the parents to obtain the card several weeks before the mother's due date. The newborn screening fee can be waived if the family meets WIC income guidelines. It has not been feasible for the newborn screening program to provide courier service to midwives. Therefore, they are given prepaid envelopes to use to mail the card. Residual dried blood spots are not made available for research without signed parental permission. Therefore, we wanted to learn how parents learn about the biotrust. We anticipated that pulse oximetry screening would become mandatory, therefore this was included in the survey. Since then, legislation has passed and pulse oximetry screening has been added to the Michigan Newborn Screening Panel effective April 1st of this year. We also know from our EDDI partners that infants born at home are less likely to have a hearing screen. Birth certificate registration can sometimes vary greatly between local registrars. Remember, our program can only find missed screens if a birth certificate has been filed. Some parents wait months, sometimes years, before applying for a birth certificate. Last, we wanted to know about the midwives themselves. We mailed the survey in the spring and followed up with a second mailing 2 weeks later to those midwives who had not returned the first survey. Along with the survey, we included the Michigan Newborn Screening Guide, which was more geared towards hospitals, a newborn screening brochure, an EDDI brochure, the BioTrust for Health consent booklet, our newly developed CCHD brochure, and the spring edition of our newsletter. By the way, we have considerable program information on our website, which is michigan.gov/newborn screening, and that's in another slide further on. We were able to include an incentive to complete the survey to those respondents who provided their contact information. We told the midwives in advance that the surveys would be de-identified and that the contact information was requested just so that we could send them the incentives. We were very happy with the response rate. Of the 34 respondents, only 2 did not include contact information. This allowed us to compare respondents to non-respondents. The 2 who did not provide contact information were included with the non-respondents. Most of the respondents had been practicing for more than 10 years, attended more than 10 births, and belonged to at least one organization at the local, state, or national level related to midwifery or women and children's health. We found it significant that roughly 1/3 of the midwives reported having at least one client whose newborn was diagnosed with the disorder through newborn screening. We were not surprised to learn that about half of the midwives work with Amish or Mennonite clients. All 34 who returned the survey have collected the newborn screen. 30 discuss and encourage newborn screening with every or most clients. 32 arranged to obtain the card prior to the mother's due date. And all but one felt confident in their ability to explain to parents the purpose and benefits of newborn screening. 3/4 of the respondents stated that more than 75% of their clients allow newborn screening. Some reasons that the midwives gave for refusal include cannot afford the card, refuse due to religious reasons, refuse for personal reasons, do not want the state to have the infant's blood, do not want the state to store the infant's blood, do not believe testing is necessary. Many previous babies had normal screens, and this was a comment. I'm not sure if they meant the mother had babies who had normal screens or babies delivered by the midwife had normal screens. One midwife wrote, they, meaning the parents, don't want me to poke their baby. 2/3 of the respondents collect the screen at the recommended time frame of 24 to 36 hours. We were not surprised at some of the barriers cited, but we're pleased to know that family reluctance was not one of them. Probably the top reason was the distance, and some of our midwives reported traveling up to 3 hours to get to a client's home. We were pleased to learn that some were already doing pulse oximetry screening, and roughly half would include it in their practice should it become mandatory. I mentioned earlier that since the survey was sent, pulse oximetry screening has been added to the Michigan Newborn Screening Panel. Some of the comments we had, many of the midwives were interested in doing the screen and wanted more instruction. Most cited the cost of the equipment as being a barrier, and one said, this is new to me, so I don't know what I'm answering to. Our second goal was to provide newborn screening education in order to improve program compliance. So remember that interest in providing training to those within the home birth community was sparked by the call from the Friend to the Amish midwives in Montcalm and Mecosta counties. There were 46 missed screens in those counties in 2011 for babies born at home. The trainings were held in 2 different Amish homes. We were able to hire a professional phlebotomy instructor for the blood spot training. I reviewed newborn screening in general, including timing of the screen, transporting the blood spot, etc. The morning session was held in Montcalm County. As a result, we trained 3 people and screened 6 infants under the age of 1 at our host home. We went to an Amish home in Mecosta County in the afternoon. Though these homes are only a 15 to 20 minute drive apart, they are quite a distance by buggy and are distinct communities. We screened 2 infants at the host home and drove to 2 different homes to collect the screen on the other 2 infants. All of the midwives expressed interest in both hearing and pulse oximetry screening as long as the equipment was battery operated. Therefore, we added this to the remaining 3 trainings that we held. Our second training was held on the west side of the state. The attendees were a mix of experienced midwives, apprentices, and birth assistants. This time we included the EDDI program consultant and our CCHD nurse educator. The next day we provided the same training at an Amish birth center in St. Joseph County, which borders Indiana. The midwife who runs the birth center is not Amish, but all of her clients are. Her clients, and often their families, come to the birth center for the delivery and can stay there up to 3 days afterwards. We split the group in 2. The 6 midwives and birth attendants received blood spot training, while the public health nurses and early on teacher received program information, as well as information on pulse oximetry and hearing screening. And then we flipped the order, and we provided the same education. Val Newton, who is on this call with us, attended this training, and we'll talk briefly about it at the end. Fortunately, funding remained available to offer another training, this time at a local health department on the east side of the state. Our final goal was to increase partnership relationships with midwives and local health departments in order to promote newborn screening for home births. A quick note about Children's Special Health Care Services, one of Michigan's Title V programs. It is important to mention here for several reasons. First, public health starts at the local level. Local health department involvement is vital to the success of public health programs. All newborns diagnosed through newborn screening are medically eligible for CSHCS. Local health departments assist us with newborn screening follow-up as needed. In fact, CSHCS funding is often what allows them to make home visits on our behalf. Lack of insurance or being underinsured in Michigan should never be a barrier to obtaining confirmatory testing for a newborn screening disorder. CSHCS will pay for a diagnostic evaluation with an appropriate pediatric subspecialist, regardless of family income, for a screen-positive infant, or what we refer to as a strong positive screen. This includes transportation assistance if needed. This is especially important for Amish families who would otherwise have much difficulty accessing specialty care. Local health departments can also provide long-term follow-up to infants diagnosed through newborn screening and enrolled in CSHCS. Roughly 1/3 of CSHCS enrollees do not have Medicaid. They may have employer-sponsored health insurance, no insurance, or be underinsured. There is a fee to join the program based on family income. Most Amish families would pay $10 a month per family, or $120 a year. Many Amish families are willing to participate in CSHCS because there's a mechanism in place to pay back the program, which there isn't for Medicaid. My co-presenter, Val Newton, is a public health nurse and the CSHCS coordinator for Branch and Hillsdale counties, which border northeast Indiana and northwest Ohio. I was able to speak about newborn screening and our Baby's First Test project at all 5 of the CSHCS regional conferences last year. I send quarterly emails to the CSHCS coordinators that include our newborn screening newsletter, and I also sent them an email about this webinar. I mentioned earlier that the Michigan Midwives Association actively promotes newborn screening. The EDDI program consultant and I met informally with members at their spring 2013 conference. We, along with the CCHD nurse educator, were invited to speak at their fall 2013 conference. I mentioned earlier that our newborn screening guide is geared more towards hospitals. I was able to adapt this guide to create a newborn screening guide for home births with input I received from many areas. This guide is posted to our website, and that's where I have it listed, along with a lot of information that's on our website, so I encourage you to access that. I was able to develop a mailing list from many different sources. As of today, it contains 108 names. About 2/3 receive quarterly information from me via email, the other 1/3 through postal mail. We plan long-term monitoring of screening rates among midwife-attended home births. We are also exploring grant opportunities to make pulse oximeters and hearing screening equipment available for use by midwives who attend home births. This is our contact information, and feel free to contact me, Lois Turbot, for more information. And thank you, Baby's First Test and Genetic Alliance, for this wonderful opportunity to promote newborn screening within the home birth community. We have some time left, so I'd like to talk briefly about the Branch Hillsdale St. Joseph Community Health Agency. This is the map I showed earlier. The 3 counties shaded in magenta on the bottom from left to right are St. Joseph, Branch, and Hillsdale. The Amish Birth Center, where we held our 3rd training, is in St. Joseph County. I'd like to turn this over now to Val Newton, who is the public health nurse in Branch and Hillsdale counties.
Thanks, Lois. The majority of our residents here are white, although there are some other ethnic groups represented. All three of our counties have several Amish church districts. Next slide, Lois, please. It is difficult to estimate the number of Amish in the United States because they are a specific religious order, not a particular race or ethnicity. We do know that they are one of the fastest growing religions in the U.S. This is probably due to them having both large families and the majority of their children remain Amish as adults. Okay, Lois. In general, the Amish are very religious and keep themselves separate from non-Amish or English as they refer to us. There is limited use of technology, and those can vary among church districts. Their church districts are small because their church services are held in their homes. As their population grows, more church districts are formed. The new order Amish tend to be less conservative than the old order. My counties have mostly old order Amish, and the families are very conservative. St. Joseph County has more new order Amish. Many of the Amish men in St. Joseph County work in the RV industry in Indiana. Okay, Lois, next slide, please. There can be many differing views among the various church districts. Some churches and some families might accept public insurance such as Medicaid. They might take WIC, although this happens infrequently in my county. They may or may not allow their children to receive vaccines. They usually seek medical care only if they are ill, and often do not have a primary care provider. Lack of routine dental care is quite common in my county. Okay, Lois. Children attend school through the 8th grade, usually in Amish schools. Families do not discuss pregnancy and childbirth. Many have home births. Hospital births are not prohibited, but are usually reserved for perceived high-risk pregnancy. And most women expect to breastfeed. We became involved with this project when Lois called me to do a key informant interview. She knew that I worked with the Amish frequently. In fact, I helped an Amish family get confirmatory testing for their baby at the University of Michigan, and I helped them to get the baby's first prescription filled before their children's special health care services kicked in. So we learned from the state that there were 35 home births misscreened, roughly 1/3 in our counties, which is how we got involved. Because we received newborn screening training, and because of our health department's ongoing and expanding involvement with the various Amish communities, the state newborn screening program encouraged us to apply for the 2014 Baby's First Test Challenge Award. We hope to continue what was started with the state's Challenge Award and look forward to reporting on our project when it is complete later this year. We are working to strengthen relationships with local midwives in order to increase the number of infants screened, provide repeat screening when needed, and we are also working with local care providers and hospitals to develop a referral mechanism for Amish babies who fail their pulse oximetry screen. Okay, Lois, I'll turn it back to you.
That is actually the end of what I had to talk about, so I'm willing at this point to answer any questions you might have.
Great, thank you for that wonderful presentation. The first question that was asked was if you could provide more details on how you developed your relationship within the Amish community in order to fulfill this project.
Well, from the state level, I have been in contact with many of the Children's Special Health Care Services coordinators who have Amish in their communities, in their counties. But I got a lot of my information from Val, who has a whole lot more experience. So Val, perhaps you could talk a little bit about what you have encountered with developing relationships.
I've been developing my relationships with them for the 8 years I've worked this position. They're very, they don't trust you at first, so it takes a while to develop relationships. And many of them have never heard about it, because when Lois started talking to me about this project in the beginning, I started asking my clients about the blood spot screening when I went to their homes, and many did not know about it. Matter of fact, many didn't even realize it contained a PKU test, and that's how they refer to it many times. So it has taken me quite a while, but once they trust you, they know you, and they are believe in what you say.
Great, thank you for that explanation. And then the last question that we had was, if you could give an example of a time when you knew more education was needed for the Amish population as well as for the midwives.
Well, all we have to look at are numbers, and so that's where we started, with just looking at the numbers of home births. Sometimes you can tell from family names if they're Amish or not. When I first started looking into this project, I only had the Amish on my radar until I realized pretty quickly that it applies to all home births and not just the Amish, and that the midwives were telling me that they have a lot of barriers with their non-Amish clients as well. So, so that's when we realized we needed to get the education, and we needed to build it from all angles. So local health departments, the midwives themselves, just getting the word out.
Okay, thank you for that response. I actually had another question come in. This question was, are the midwives reporting pulse ox screening data? And if so, how are they reporting?
Well, at this point, nobody is reporting pulse ox data officially, because it's not part of our panel. But we do happen to have our CCHD nurse educator in this room, so I can pass it over to her, and the phone over to her, and she can talk a little bit about what we have planned.
Hi everybody, my name's Carrie. I'm the CCHD nurse educator here in Michigan. Through our training with the midwives that we've done, we have discussed the pulse oximetry project and the need for reporting once it becomes part of the mandate in April, and we've offered them a couple of different options once they begin screening to report the data. The first one would be just to send us paper sheets. We've created a report form that they can fill out with the information and send that to us in the mail. We've also discussed them possibly sending it in with the blood spot cards when they send those in. And then the other option that we have here in Michigan is actually an online reporting tool. And we did learn that a good majority of the midwives are open to using the internet. They check email. They have some access to it, whether it be in their own home or through other means. So they're open to doing the online reporting to us as well, which some of our hospitals will be using. So we've offered them a couple of different options for when it comes to reporting the CCHD data to us.
And another question that we had is, if you could talk a little bit more about how you could apply what you've learned in other Amish communities to implement the same project, or other communities that are away from mainstream culture.
You mean in newborn screening, or just in public health programs in general?
If you could talk to both, that would be great.
Well, I'll talk just about newborn screening. I think one of the most important things is to identify who the players. The Michigan Midwives Association has been very helpful to us, but we realize that they are probably a biased group to get information from, because they already promote newborn screening. So what we want to be able to find long-term are the midwives who are attending home births and not offering it. We plan on that when our epidemiologist comes back from maternity leave. We're going to pursue this further. by looking at birth certificate data and getting names of birth attendants and figuring out just who is not offering newborn screening. If we see a name crop up at least 3 times, we'd have a pretty good idea that this is somebody who's attending home births, and we'll want to contact that person to offer education. So that's probably one of the important things to know. I do know early when I first arrived, I had a call from a midwife who the parents had contacted her to do the baby's newborn screen because their midwife, they were told that the midwife would only accept them as a client if they did not have the newborn screen. So this midwife who called me would not give me this midwife's name or contact information because, as she puts it, I'm very protective of home births. But she also was a midwife who does the newborn screen. So she did do it for this client, and I had no way of knowing who that first midwife was. I've also had another woman call me who was expecting her second baby. She had had her first baby with a midwife and did not have the newborn screen. In fact, the mother said she didn't know anything about the screen until she got the letter from us. But because this birth certificate had been very late being filed, the baby was already a year old, and so therefore could not get a newborn screen from us. So her first one never did have the newborn screen. So this mom had read up a lot and decided she does want it for her second baby, and her midwife said, well, I don't really recommend it, so I'm not going to do it. And it kind of surprised me because this particular midwife does submit newborn screens. I don't know what her percentage is. I plan to pursue that. But I have seen her name come up quite a bit on newborn screens, so I don't know what's going on there. I did tell this mother that by law, birth attendants must offer newborn screening, and this mother actually was looking into finding another midwife to do the delivery or possibly delivering at a hospital birthing center. So that's where I would start, is to find out the players. And it's going to be kind of time consuming, but it's worthwhile for us to do that. Then when it comes to other perinatal health issues, I kind of want to turn that over to Val because she has experience in the home with the Amish. So Val, maybe you have something to say.
I just want to encourage them to get the follow-up care and get the testing done because that's a big issue. And then I can help with my children's special health care role in getting them help and getting them to the appropriate doctors. Also, I do follow-up for Eddie for the hearing screens, and there's a lot of kids that are lost to follow-up, so I'd like to pursue that more too, to get more kids their follow-up they need for hearing also.
But Val, maybe you can talk about some of the other health issues. One of the things that came up that I found, because the hepatitis B information is on our card, it's not part of newborn screening. It's a different program within the community health. But I do notice that this information is usually missing from the newborn screening card. And I know from talking to the midwives that many of them do not provide any type of hepatitis B screening. They don't talk about hepatitis B vaccines. And this is something that's on my radar that I'd like to explore with our hepatitis B program to see if we can't get more education out there. Val, do you have any more to add on? Oh, speaking of hepatitis B also, he said that if the midwives are having problems getting the screening done, he thinks it should be pretty easy to arrange to get it done at the local health department through their program. So Val, do you have any comments on just health issues in general?
No, I know that they're low on vaccines. You know, they don't get vaccinated a lot, so we've been working with the immunization coordinator when we go into the schools to do their hearing and vision screening. to see if we can't encourage them to get some vaccinations. I know they've gone to different facilities and vaccinated, you know, a group at a time. So we are making some headway there, but they do have all kinds of medical issues.
Val, maybe you could talk a little bit about how the early on teacher got interested in coming to our training.
She has a huge, you know, the Amish don't take much help. They like to do things themselves. She came into one of my homes and started building a relationship with some of the Amish in Branch County, and she is very interested in getting them the help they need also. She drives them to appointments many times, attends their doctor's appointments with them just to help explain things, and she's a huge asset in Branch County. And that's why she came, because she's very interested in the Amish population also. You know, they're a very caring population. It does take a while to build their trust, but they also take her to different houses now with kids with medical issues, and that's why she tries to explain them, and she tries to get me in the house after that. So we have a really good working relationship, and I think that's what we need to work on, is building a community relationship with different community members.
Thanks for your response to that question. We had another question come in, and the question is, did you have funding available to purchase the pulse oximeters for the midwives, or were they responsible for purchasing their own equipment? And if they had to purchase their own equipment, what resources did you provide them to assist them in purchasing their own equipment?
We're currently looking into what we can do to help the midwives purchase equipment. We don't have any really permanent plans right now. It's something that we are looking into. What we did learn when we were doing the trainings is that the midwives were buying pulse oximeters off of eBay or Amazon that were not meant for use in babies and not real accurate compared to the pulse oximeter I had to do the trainings with. So that is an important thing that we're looking at and trying to figure out now how we can best supply pulse oximeters to the midwives to use.
Along that line, the EDDI program consultant is also looking into grant funding for the hearing equipment. We recognize that both of those are a problem because they'll now be required by law to provide the service, and yet it's difficult for them to do it. And so we were trying to figure out if there's maybe local health departments that could house the equipment for the midwives to check out and return, or if amongst themselves they could pass the equipment around. So we know that this is something that we need to address, and we're trying to figure out how to do it.
Another question that came in was, can you elaborate on what the local health department's role is in following up on newborn screening?
Okay, I'll talk a little bit about that. Most programs are like ours, where we have the borderline positive determination, which means the baby needs a repeat screen. And then we have the strong positive determination, which indicates the need for confirmatory testing. So the health departments were pretty receptive to me contacting them. I have a way of doing it securely through something called EasyLink, which is a web-based application that is secure and a way of sharing medical reports. So I can contact local health departments, the CSHCS coordinator, that way, so that if we have a baby that needs a repeat screen, I send them the information, and when possible, they make a home visit if they, if we are unable to find the parent to get the baby in for a repeat screen. This happens most frequently in the Detroit area, and their health department is very quick about getting out there and contacting the families. And also Wayne County, which is everything but Detroit. And their nurses also will make visits. And I would say the majority of this happens in with those two health departments. Now, the screen positive, the strong positives, is another matter. we in Michigan have our management centers for all of the disorders. So once a baby is screened positive, the case is turned over to the management center. They all are aware of children's special health care. Not all of them make the contact because one of the problems we run into is that they assume that because the family has commercial insurance through employment that everything is covered, when in fact it could be January and the family hasn't met their deductible and there could be a huge cost involved with this. And that's where children's special health care comes in play with the diagnostic evaluation. So the local health departments in all of the counties offer this service to families, and that's how Val got involved with that one case in getting the family to the University of Michigan for testing. So CSHCS in this case, when there's commercial insurance involvement, they act as a secondary insurance to cover the non-reimbursed medical portion of the bill. I hope that makes sense. There are over 2,500 medical diagnoses covered by CSHCS, so all of the disorders on our newborn screening panel are included in those medical diagnoses. So that's why if you are seeking a diagnosis, why the diagnostic evaluation is used. And then if the child does have the disorder, is confirmed to have it, they're medically eligible to join CSHCS. And that's administered at the local health department level, which is what Val does.
Great. We have another question, and it is, how are the home visitors funded to do the follow-up, and is it through Title V?
Okay, our CSHCS program provides funding to health departments for outreach and advocacy. So it's like a block amount of money that they get. And this is why they are often allowed to make home visits. It's a little bit gray area with a borderline positive that just needs a repeat screen because they may or may not need confirmatory testing. The health departments that I have approached to help me have all been able to do that. So it's not a separate fee that we're able to provide to them. Where if they make a visit, we will pay them X amount of money as in other public health programs. But we haven't experienced a problem with, at this point, with them doing the follow-up. Now, when it comes to children who are actually enrolled in children's special health care, then there is additional billing that they can do for their home visits, which helps bring in more revenue for them to sustain their program.
Thank you. Another question is it too early to see a difference in screening rates for home births?
Yes, for two reasons. One, we just got our 2012 data a couple months ago, and we finished up our last screening in August. So it's going to be long-term, and plus we want to be able to, so some midwives might deliver 3 babies a year, some might deliver 30 or more a year. So that's why we plan long-term follow-up to see if there's improved rates.